Good day and welcome to the PDS webinar, Data-Driven Analytics, Modeling Changes to Compensation. My name is Russell Hendrickson. I'm the President and CEO of PDS, and I'm pleased to have joining me Scott Everett, our Vice President of Healthcare Solutions.
Thanks, Russell. Thanks for joining us today, everyone. It's good to have you here. For those of you who aren't familiar with PDS, we are a healthcare analytics company who has expertise and experience in a lot of topics around healthcare, ranging from professional and hospital revenue cycle to patient access to the topic we're talking about today, physician compensation.
Yeah, and this is the last part of our 6-part webinar series. In the first 3 parts, if you were able to join us, thank you. Part 1, Part 2, Part 3, we talked about optimizing patient access. We talked about denial recovery, and we talked about leveraging HCCs to improve care. And the question might be, well, why are we ending the series with physician compensation analytics? And the answer is, well, all of those metrics might play a part in your physician comp plans and just some of the pieces that you might find in those plans.
Yeah, as we meet with more and more clients around physician compensation, you find that it can get pretty complex to try to automate all of these data points that are out there. You may be getting data from different systems and the data may not work really well with each other. It can be fairly complex. Your data can be kind of a mess. And the real trick here is to try to turn what you see here into something like this, where you have an interactive visual that can be utilized by physicians and management, showing key trends in the calculation of the compensation with some other supportive metrics that may help the physician self-manage. But it can be tough to get there.
Yeah, and so, where do you start with modeling that data? And again, why is this webinar here, part 6 in our series? Well, we talked in part 4 about creating what we call reusable data models, using this data mart approach where we might segment out, RVUs and then utilization and then collections. And then we might need to add into that, quality goals, patient satisfaction metrics. And so, out of modeling your data, really being best practice data driven, you then have a structure that will support what it is you're trying to accomplish. And then in part 5 of our series, we talked about customized KPIs and the need for organizations to have unique counts like cases, patients, unique patients, new patients, what I call new old patients, right? Patients that haven't been seen in the last 3 years, but are still part of your practice. And so those custom KPIs really play into what's going to show up in your compensation plans, right? And in order to be effective, not just physicians, but the whole organization, there's a lot of different data points that might come into play. And that's what we're going to be talking about today, is how do we align those data points and make something structured both for where we are today with automating compensation, but also where are we headed with changes in our industry that are going to require us to realign compensation or continue to align compensation.
Yeah, and I think the key word that you used there several times, Russell, is align. We need to make sure that the goals that the physicians have with regard to their compensation really align with the practice as a whole and the organization. And we need to really understand, a couple of different things. We need to understand how the physicians are currently paid. We need to know, is that fair or common in the market? Is that something that we can utilize for retention or recruitment efforts, or is it working against us? We need to understand our own reimbursement and what those key drivers are, and what are the changes that are coming through, what new plans are coming into place with value-based care, with what our payers are trying to adopt, what's changing at CMS. As you can see, sometimes significant changes there or just even little changes there can have significant impact. And really, the goal is to try to take all of these different drivers and all of these different metrics and put into place a compensation plan that has the providers moving in the same direction as the practice itself, and how we can best utilize this to our advantage, both competitively as well as financially.
Yeah, change is what's driving a lot of where we are. But let's talk about where we've come from, or where a lot of organizations are today. And today, many comp plans, probably the majority still are driven by volume type based plans, fee for service plans, RVU based plans, plans that are based on reimbursement as a percentage of Medicare. So, that's what we've seen, and we'll examine those kind of typical comp plans that your organization might be using. But, Scott, as you pointed out, things are changing. So we have to also be able to handle where we're headed. And many organizations are moving in this direction. But take us a little further into this, if you would.
Yeah, so we're starting to see payers start to move in this direction where they're looking at more value-based and population health and helping keep patients healthy and reimbursing along those lines. And so as we move providers in those directions, we have to understand that obviously the volume, the productivity, that's still very critically important. We need to make sure that we're rewarding that and looking at that. But we also need to start factoring in cost containment. We need to start factoring in metrics related to patient outcomes and quality, and of course, patient experience or patient satisfaction. All of those come into play as we start looking at new healthcare models. And so as we look at, the way we can model and reflect each of these plans, let's take a quick look at a visualization that we might use.
So what we're looking at here, fairly common, many organizations still primary driver of physician compensation is an RVU-based plan. This is a visualization of that. So, in addition to seeing the RVU production, which might be some kind of a bonus scale, hitting higher tiers, as you can see, this physician, we've got sort of there in the red tier, which would be the bottom tier. But if we go back to this other physician we were looking at here, they're on track and they're sort of hitting that top third or fourth tier, obviously trying to maximize their compensation. Fairly common too with some RVU plans, more and more organizations moving to maybe a small percentage, something that's either patient satisfaction driven, quality driven, or some kind of incentive pool. And so this visualization not only showing what the physician has earned, but also showing us what is available in the compensation that potentially is being missed because we're not hitting those earnings.
Yeah, so this I think is a good example of being able to reflect what's going on, and it shows some key metrics. It shows performance tiers, and it shows the calculations. And I think this really reflects what are the key types of things that we want to have in the ways that we're communicating with our physicians. And I'm going to say this a lot today, that the biggest issues when we're trying to model and trying to communicate and report on physician compensation are transparency and trust. And so we need to make sure that they have everything that they need to be able to utilize what's coming to them to help them self-manage so that they can optimize the compensation that they want to receive. So they need to understand the calculation and the overviews that come into play. They need to look at the performance goals that are expected, maybe RVU tiers, collection tiers. They may need to understand the quality goals and what's expected of them, as well as maybe what's going to be involved in the clinic's goals and how the role that they play in helping the clinic to obtain the goals that they have.
Yeah, Scott, I'm reminded of working with a client one time, and one of the challenges that the manager had expressed to a physician was constantly complaining that he wasn't earning enough money. And so, compliance with contract, in digging at the supporting metrics, and we're going to look at some of these coming up here, he found right away that the physician was undercoding, a lot of level 1, level 2. This is back when physicians were doing more of their coding. But, it had been right after sort of a compliance webinar. Then on top of that, the physician's available hours were not up to compliance with the contract. So, by having the data and the metrics behind and providing some of those supporting metrics to the physician, certainly making it easier to see right away, things are out of alignment here. We've got problems with coding, we've got problems with scheduling utilization, and ultimately that's driving, lower performance and reimbursement. So in any case, another plan, what I call one of the more common plans that you might see, this is a revenue production or a collection type plan. Many people know this as the eat what you kill type plan. And the idea here is that, physicians are bonused on the amount of revenue that they help bring in. Fairly common still today with a lot of private practices or specialty driven practices where even you have subspecialties, orthopedics, et cetera. And here, as you can see in this comp plan, we can see the revenue production and then how that translates into some kind of a monthly or quarterly bonus along with whatever their base salary or their salary draw might be. So you can see that related out. But of course, we're still showing RVUs or revenue production, things like charge lag, payer mix, et cetera, helping understand even, of course, those E&M codes, as we were just talking about, helping the physician understand what are the supporting metrics that might be impacting their ability to drive revenue.
Yeah, and even as we move to value-based, this is a very, very common plan that we're seeing more and more. I think where I've been seeing this a lot recently is with practices that are venture capital backed. And moving in that direction, or ones that may have different levels of cosmetic or retail products or services that they provide to incentivize with that as well. So this is still a very common approach to physician compensation. The next one is kind of the direction that we're moving in, and we're starting to see this more and more in larger health systems that are integrated. Hospital and physician health systems may have a physician employment model, et cetera, but these are ones that are taking on more value-based care. And the way this works is this is more of a base salary where the employed physicians are receiving a base salary for their services, but then they're incentivized on the number of patients in their panel that they see and that they're required to manage. Looks at the risk adjustment scores of these patients that they're working with, and it kind of modifies a per member per month bonus that they have for managing their panel. They're also looking at and bonusing on quality metrics. They're bonusing on patient satisfaction metrics, but really, what they're trying to do is make sure that they're getting all of their patients in and that they're providing a very high level of quality care, particularly for those patients with chronic conditions. And so you can see, the patients who have had their HCCs scored and their risk adjustments calculated, look at wellness visit utilization rates and set targets along those lines as well. These are kind of common trends in more that value-based area.
Yeah, and what's so interesting about this, and even one of our programmers commented to me about, it's easy to sort of design plans or design metrics that look at patients, who is a primary physician, et cetera. The biggest challenge though is either getting organizations to manage on them or getting the physicians to understand what their impact is on controlling some of those metrics. So those are some of the challenges we face as we move more towards value-based care type planning. But I would challenge, again, good data and analytics and timely information, right? Being able to provide, even if it's the supporting metrics to help the physicians understand their utilization rate and such, still helps drive organizational goals. But those are kind of three of the more common type plans that we see organizations having something on. There's one other area, Scott. Why don't you talk to this one here?
Yeah, I mean, we talk a lot about those three because those are the most common. But if you work with academic practices, that they may come into play with research and academic components that they need to add in, or you may have agreements with the hospital where it's not necessarily an integrated health system, but they provide stipends for call coverage or for medical directors or things like that. And so you have these hybrid models that you work with that can have a number of different factors that come into play. And really all that does is make the reporting a little bit more difficult because you're now having to pull data from even more disparate data sources in order to get accurate information.
Yeah, and so the real challenge here is, what do physicians need? What do they need for compensation reporting? So we've looked at some sample dashboards, we've looked at some different types of plans, but our experience, and I think you'd hear this with most physicians, is they want visual analytics. They want dashboards that are robust, that tell them and show them how they're performing. Timely data, just critical. And that's somewhat challenged with our value-based care, as we'll talk about it, because it's sometimes hard to get information timely. Automated, obviously, we want it accurate, we want it automated. And then, of course, we want to be able to provide, the context so the physicians can understand how are they performing, where could they performing, how are they performing against internal, external benchmarks, and ultimately, then they can manage their performance and try to improve on their performance. If we don't give physicians the information they need, and I've heard in some cases we provide comp reports. I actually heard this from an organization twice a year. Right. So to me, that's equivalent to flying blind. We don't have the information to know where we're headed. We don't know if we're on track. So how can we really control our performance, and how does that play in? And that's just, in today's data-driven world, that's not really acceptable.
Yeah, I think on the flip side, what you have is, we've talked about the complexities of these plans that are out there, and trying to gather all of the data from all of the sources can be really time consuming. Getting it out to all of the providers, especially if you have 200 or 300 of them that you're trying to deliver it out to, can really take some time and effort as well. But really what used to scare me the most is when we're trying to do everything manually, is that manual processes tend to be error prone, especially when you're repeating the same things over and over and over again. You can lose sight of what's going on. And the fact of the matter is, one error in these reports undermines the trust of the entire process, and it's really tough to get that back. And so really automation has to be the key on this one, because the more manual process you can take out, the better it's going to be for everyone.
Yeah, without a doubt. And so what we're really talking about here, and this is in the title of our webinar series, is what does it mean to be data driven, right? So we're applying data driven principles to physician comp, but let's take a step back and talk about that. So data driven organizations, their focus is on the continuous use of data. They understand that by applying data, consistently, there are opportunities, there are performance gaps. We can see who's performing well, we can see who's not performing well, not necessarily to punish or penalize, but to shed light on the fact that there's performance here. There's room for improvement. And then ultimately, we use those insights from data to not only improve performance, but to measure performance improvements and then manage on those performance improvements so we don't have slippage. Unfortunately, in healthcare, and we continue to see this, there's challenges, and Scott, walk us through some of the common ones. To me, the biggest one is time and money. But
yeah, I mean, those are obviously going to come into play. Is anytime you do something like this, you need resources, you need expertise. But again, what makes it difficult is you may have an organization that doesn't just have one plan. You may have multiple plans that you have to try to model, and they may have different metrics, or some are the same and some are different. You have a lot of one-offs where you may have, a single plan, but this provider gets this benefit or this provider gets this, and a lot of things come into play with that as well. And so you also have issues with data accessibility. Can you even get all of the data that you need in order to automate the process effectively? And so really all of that comes into play. And that's kind of why you see and hear about these organizations. We do it twice a year because we just really don't have the resources or expertise to be able to do it more often than that. But I think at the end of the day, that kind of might probably hurts the organization with what they're trying to build with their providers.
Yeah. So, thinking about it, and we've talked about this in the past webinars, but let's go a little further. So it's not enough just to provide the physicians with dashboards. It's not enough to, create a picture and send out a PDF or email it out, right? It's being data driven means that the data behind the dashboards is visual, it's interactive. The physicians, as well as the leadership, as we'll show in just a minute here, can move in and out of what are data cubes or this slice and dice analysis type capabilities, and then even drill all the way down to reports, looking at the procedures, looking at the performance gaps, looking at the patients that haven't been seen. And of course, in order to support being data driven, we have to have the structure underneath, which is that optimized data warehouse. So going back to the puzzle, Scott, that you shared in the beginning, how do we align those core components, the metrics, not only used for comp, but the metrics that really support the organization? And if we've modeled out that data appropriately, which was, a big part of what we talked about in our part 4 of our series, how to model data so it's reusable. What's so interesting is if we've structured it appropriately, it doesn't matter what tool we use, whether we want to use something like Power BI or Tableau, or some of the more sophisticated Click MicroStrategy tools that sit out there in the market. Our structured data means that we can have the analysis and the metrics and the supporting details behind them. So everybody in the organization can access what they need.
Yeah, and I think what's really a key there is having that single source of truth, because what's going to happen is what the physicians need to see may be a little bit different than what executives see, or what maybe the finance team needs even a little bit different perspectives. They're trying to model out maybe new compensation structures as the practice evolves, things like that. But really the key is that you can seamlessly go from the visualization to the slice and dice to any detail that the providers may have questions about moving forward. And so if we get back to this plan, what you can see here is, something like this is a great provider look for a dashboard where, again, it shows the calculations, it shows individual providers where they are and what they're projected to receive at the end of the year. It shows the supporting metrics behind it and the key trends. And I think this is a good view. And I think where you go from here is that this gives you that high level overview.
Yeah, and as you mentioned, Scott, but if we want to allow users, whether it's management, physicians, to dig deeper, we can provide, because we've structured our data appropriately, we can provide that drill through capability. So just clicking on RVUs, you can see I moved from the visual analytics into what is a data cube, a slice and dice type capability, where I could continue to add filters, slice and dice through the data, look for outliers, add metrics that didn't exist in my initial visualization, but they're all supported by these tools. And then ultimately, if I want to drill through, I can just point and click and go from literally that slice and dice cube analysis all the way down to the patient level detail. But you notice I didn't have to write another report. I didn't have to go to another tool, right? So having everything in one place where I can then continue to get to the numbers. If I want to validate, did all the patients that I saw get put into the system, and am I being, rolled up correctly? I have the detailed reporting. I have that slice and dice capability to explore the data and look at the outliers. And of course, it's all supported by a single visualization, which is ultimately, being data driven. It's not just enough to send out a picture of here's the number.
Yeah, a number of years ago when I was managing physician practices, there was a provider who didn't just want to know their numbers every month. They wanted to see every patient and every procedure code that they performed during that month, so that they could make sure that they were reconciling. And so, having the tool to be able to do that without having to create a bunch of different reports is definitely helpful. This is another look that, what we just showed was a great provider example, but management may want to look at all of the providers at one time, and be able to go in and set some filters and look, here's what is going on at cardiology. We can see who are our highest performing providers from an RVU standpoint, but maybe we can see, who are our highest performing providers that are doing well from a salary standpoint, but maybe they're not meeting their quality goals. And so being able to look at that and narrowing it down and providing that management perspective can really be a key as well.
Yeah, and then appropriately the same thing if we have management using a tool like this, and when we want to dig further, maybe we need more drill down to the data to understand, just what you said, Scott, who are those top performing providers, yet they're missing their patient satisfaction metrics, because even though they might be seeing a lot of patients and ultimately driving revenue through the practice, not hitting our patient satisfaction scores could ultimately be causing patients not to return to our practice. So in the long run, it might actually be hurting our organization. So the same rules apply, being able to look at data, explore data, and ultimately understand what's going on.
Yeah, and an additional perspective then may be something like finance or HR. Finance, where we may incorporate budget numbers and start seeing who are the providers who aren't hitting the budget that we had set for them, and understanding where they are. Or I've always kind of liked these quad graphs that you can see where you show two different metrics and who are the low performers in one and high performers in another. So you can see here right away who are your high performing physicians who are, your highest compensated, but then you may have a very highly compensated provider who does not meet the productivity threshold that would go with that. Or you may have one who actually is a fairly high performing, very productive provider, but isn't compensated accordingly. And that's one that we may be at risk of losing, and we want to start putting retention pieces into play. So these are all areas that can come into play and be very helpful to look at, from a management perspective as well.
Yeah, and so one thing I want to point out here is we're exploring comp metrics and the supporting metrics, the same things that we're looking the other visualization, but we've switched from the PDS Empower tool over to Power BI. And so the big question is, well, how can we enable metrics with different tool sets? And the simple answer, it comes back to by having the model data, by pursuing that data-driven strategy. The tools really are just supporting how we interface with the data and how we want to communicate. And that's the job of data and analytics, is to support the organization, right? So it makes it much easier whether we're trying to get information in the hands of physicians or we're trying to do analysis. We have the flexibility to look at it any way we need.
Yeah, and so I think it's really important to not just look at it from a compensation standpoint either. If we really want to optimize what we're doing and really optimize our physicians' trust and the transparency that we have, we're not just giving them, here's where you are, go. We want to show them what they can be doing in order to improve and self-manage their compensation as well. So we look at something like this where we can say, here's the number of patients that you've seen during the year, and here's some patients that haven't even been in. And when you look at a process like this can help providers understand, especially if you're on a quality plan, where they can improve and maybe do some outreach to bring in some additional patients and help fill both volume quotas as well as quality quotas. And so if you take and couple this data with, for example, scheduling data and risk scoring data, you can come and create a visual like you see here, where you can, filter down on your highest risk patients and see who are the ones who are past due for a follow-up appointment, who haven't been in a while, for us to help them manage their conditions, or who doesn't have an appointment scheduled coming forward, who hasn't been scheduled for an annual wellness visit in the past year. All of this can come into play to help the providers find outreach, which again can help to increase their volumes as well as increase quality and patient satisfaction.
Yeah, Scott, and that's a great example where we're starting to shed light on where are there gaps, where are there patients that are being missed, right? And so we like to talk about this. We call this our performance opportunity reporting, which is we're looking at different how we're performing, and we're really starting to benchmark. And so you'll notice in the example here that whether we're labeling physicians or front desk staff or denial follow-up billers, right? We can stratify the population and say, who are our top performers based on some metric? Who are the bottom performers based on the metric? Who are in the median, in the middle? And ultimately, can we use data to understand how are the top performers performing, where the bottom performers not performing? And if we can drive up those bottom performers, even to the average of the organization, or drive up the median performers to be better top performers, ultimately, regardless of what we're looking at, right, we can improve the organizational performance. And so when we start thinking about that with physician productivity, that's what we're trying to do here. We're trying to use data to shed light to improve performance. So ultimately, though, that will then help us drive forward projecting, because that's what we started to do, because we can quantify who hasn't been seen that needs to be seen. How do we then project that data into an ROI?
As we've been doing this webinar series, we've talked about this all the time, about achieving the highest levels of analytical intensity. And that highest level is projections, like you talked about, where we can utilize what we've done before with our data summarizations and trends and benchmarks. We can add some other metrics in, and we can start projecting what would happen if X metric were to be improved. And so you can look at something even just like annual wellness visit utilization rates. Now, we work with a lot of clients, and in most places, there's not a very high level of wellness visit utilization. Yet a lot of these patients are coming in for follow-up care, office visit care. Well, if they were to utilize their wellness visits a lot better, they would get more complete risk scores. They would get more complete diagnosis scores. They'd also get reimbursed better for those wellness visits. So this is going to help physicians on RVU plans, on collections plans, as well as on value-based plans, because every physician who's below average, if you can drive them up to that average level, there is a significant financial opportunity that exists with each of them.
Yeah, I mean, it really is that simple as understanding who are the bottom 20%. Can we drive their performance up? And because we can now measure that, we can see that performance gap, we can ultimately put an estimate on or project what the performance improvement is. And we've seen executives use this to justify hiring in consultants, hiring in more staff, because oftentimes that, driving the bottom performers up, driving change, education, training, right, modeling after who the top performers are, has such a huge impact on the organization. It's fairly easy to then justify why we should bring in additional resources or where we want to focus.
Yeah, and especially with compensation, there's another really key area for projections, and that's for organizations that are looking to incorporate new plans. And the reason for this is because as we shift from volume-based plans to more value-based plans, again, that trust and transparency is going to be absolutely critical going forward. And what we're going to need to do is before we change the plan, we're going to need to create multiple examples and models and share these with the physicians, showing visuals for these plans, the results that would come through. They need to compare salaries of the physician across those periods of time, and then help the providers understand what particular behavioral changes or productivity increases they need in order to get to the level of compensation that they desire. This is something that's absolutely critical if you're trying to change.
Yeah, so let's take a look at one more visualization here, interactive visualization. And this behind the scenes is probably one of the most complex that you've seen, although as you can see, there's a lot of crosstab data on this visualization. This is the current plan in the green. The dark green is the forecasted plan, right? But then we're calculating the difference. Now, the key to being able to do just what you said, model the difference in the plans. The key to this is if we don't have our current plan automated, there's no way we can then model a new plan and start to run it through the model to start to understand who are the winners and who are the losers based on the changes in comp, even if it's just thresholds, even if it's adding more quality metrics, right? So ultimately what we want to be able to do is slice through that data. Maybe we want to look at cardiology or we want to look at family practice, and we can start to see cardiologists would benefit. They're going to see an increase in the new plan, with a few of the bottom performing physicians seeing a decrease. But if you look at family practice, and this may not be a good plan, especially today, right, where we can see there's quite a huge impact on those bottom performers.
Yeah, and this is really something that I think from a management perspective is very, very helpful to see who are the individual providers that you're going to have to work with to manage to where they want to get to. Who are the providers who are going to be big winners that you can help to recruit them to get buy-in to the new plan as well. Things like that are really, how do we engage with these physicians? And if we want to start, if we're even thinking of moving to a new plan, before we start modeling it out, let's start engaging these physicians. And let's start engaging them with the new metrics that they're going to be that they're going to be based on, and start showing them, panel numbers, attributed populations that they have. Start showing them potential quality incentives or quality goals that we're going to be moving towards. Help them understand patient risk scoring and population health. Help them understand where they fall short in patient access, patient satisfaction before it starts impacting their compensation, and help them to start moving those up before you start modeling these new plans as well, and start giving these providers the supporting information that they really need.
Yeah, Scott, and again, I'm reminded working with one of our clients about a client who literally took a 2-year approach to changing comp. And so in year one, they said, we're not going to change any comp in the first year. We know where we're headed. We know what's coming. But in year one, we're going to do something like this, which is show you, here's our current comp calculations. Here's what you're earning today. Here's what you're getting paid on. But not this year that we're measuring you, but next year, this is where we're headed. So we're starting to introduce these new components of plans. We're showing you them, and we're even showing you your performance against the new plan, so you can start making those changes, understanding, working your way through, having the data to try to drive better performance. And so this ability then to model new plan against current plan and sort of think long term. We can't introduce metrics to physicians they've never seen and then expect them, to suddenly be able to manage to that. If we're going to try to drive change in our organization, we've got to be able to provide the supporting information and then the education behind it to make sure that everybody gets on board. And that's what's going to make us successful as we drive forward. So with that, I'll talk to sort of some of the key takeaways we've talked about here today, which is more from the data side. Physicians obviously needing good information to do reporting. I would challenge your whole organization, management, leadership, and even, people in key roles need access to data to understand what's going on and understand the gaps. Scott, you mentioned that accessibility and transparency are essential to being data-driven and certainly essential to good physician comp reporting. And then, I would even challenge your organization, whatever you're doing today, review your current design, solicit feedback, get a cross-functional team in place and say, how do we improve this? Is it timely enough? Is it visual enough? What metrics don't we have? Do we need to add a second or third page to our dashboards just with supporting metrics to help the organization and the physicians and the leadership understand where those performance gaps are?
Yeah, and I think really what we need to understand too is, what are our clinic goals now? What's the organizational goal? What is the practice striving for? And make sure that we're starting to get our providers in sync with those goals as well. And understanding what are the payment reforms that are coming down right now that are going to impact us, help us to understand what we need to do as a practice and get our physicians to maximize the reimbursement as a practice. That's going to be critical to be, financially strong going forward. And then don't try to drink from the well right away. Start small and over time that can yield big changes. You can't make this change overnight. It could have, pretty dire consequences if you do. And just understand that healthcare is always changing. We need to make sure that we can evolve as a practice from the way that we pay our providers, as well as to the way we bonus our providers, as well as the way we treat our staff, the way we recruit providers, the way we retain providers, especially in this market where there's a provider shortage. All of this is critical for us to maintain our goals. So we need to make sure that we're doing the best we can for our providers, our patients, and the practice at the same time.
So thank you very much for attending today's webinar. At this point, we'll take any questions you may want to chat in using the Q&A button in the webinar toolbar, and we'll be happy to stay online and answer as many questions as we can. So please feel free to chat in your questions. We'd be happy to answer them at any time.